Hi, I'm Dr. Jochelson. I'm a diagnostic radiologist, and I'm the Director of Imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center. So the BIRADS system is a language that we use to help us characterize findings on imaging. And it is a method to speak the same language by describing lesions as everyone else reading those studies. And that language helps us to then characterize the likelihood of cancer in that patient in the same way as everybody else is doing. BIRADS is used for mammography, breast ultrasound, and MRI. And every report that we do has 3 parts as dictated by the BIRADS system. So the first thing we do with mammography and MRI is to describe the breast density. The second thing we do is to describe the abnormalities using specific terms, and I'm going to talk about that a little bit more on the next several slides. And then once you have described the abnormalities, you assign a BIRADS number that is associated with the likelihood of cancer and a standard recommendation of what to do next that goes with that BIRADS number. So we start for mammography, and we characterize breast density, which can be almost entirely fatty, that's 10% of women, scattered fibroglandular tissue, which is 25% of women, heterogeneously dense breasts, another 25% of women, and extremely dense breasts, which is 10% of women. When we do MRI, we characterize density, but we also characterize something called background parenchymal enhancement. And this is the enhancement of normal breast tissue, which is something that we look at both on MRI, and if you can see on the top images, this is for contrast enhanced mammography, which is a technique which is similar to MRI, where we give women dye, which helps us find cancers earlier. And so for BPE categories, minimal, mild, moderate, and marked. And one of the things we've learned is that women with dense breasts and women with more BPE seem to be at higher risk of developing breast cancer. So these are important things to state right at the beginning of every report. For ultrasound, we don't have to discuss density, and there is no BPE. So once we have described the nature of the breast, we begin by showing masses. And on mammography, what we talk about is the shape of the mass. Is it round, oval, or irregular? And whether the border is smooth, irregular, or spiculated. And each one of these characterizations has with it an association with the likelihood of being a malignancy. On mammography, we also get calcifications, which may be an early sign of cancer and may be benign. So we have to describe those as whether or not they are grouped, and if they're tightly grouped or not tightly grouped. If they are small calcifications, microscopic calcifications are the ones that are generally thought to be more suspicious for cancer. However, larger calcifications may be malignant. Are the calcifications all the same, or are they heterogeneous, all different shapes and all different sizes? That too seems to be more likely to be associated with cancer. And how the calcifications are distributed within the breast, whether the calcifications are similar in both breasts or they are asymmetric or a little bit different from one side to the next. On ultrasound, we also describe masses, which are the primary findings. And again, the shape, round, oval, or irregular. the margins smooth, irregular, lobulated, or microlobulated. So you can see that the terminology is a little different with ultrasound. The echogenicity, are these masses mostly black or are they mostly white, which indicates hyperechogenicity. The other thing we look at is whether the mass is parallel to the chest wall or not. Parallel masses are generally thought to be more likely to be benign, and non-parallel more likely to be malignant. The other thing we check with ultrasound is for blood flow. When women develop cancers, those cancers develop new blood vessels called neovascularity, which feed the tumor. And so when we do ultrasound, we can see if there is increased blood flow to the masses that we are finding. On MRI, we have a different language. Rather than density, we really call it fibroglandular tissue, but it is a similar categorization to that of mammography. We, as I've told you before, look at background parenchymal enhancement. When the patient has a mass, we describe it like mammography, sorry, not MRI. And we also have something different. We have something called non-mass enhancement. And that is enhancement that goes in a line rather than forming a mass. And this non-mass enhancement can also be an early sign or a sign of breast cancer, or can be benign. With MRI, since we use contrast material, we also look at kinetics, and that is the speed at which the contrast gets into a mass that you see on MRI. So if you have a mass and the contrast goes there early, that is generally more suspicious for a malignancy than if the contrast doesn't get to the mass till much later. So once we have characterized the density, the BPE, if there is any, the masses, the calcifications, and the issue of blood flow, we are ready to assign a BIRADS number. So BIRADS 1 is negative. BIRADS 2 is benign, which means the patient may have a benign mass or benign calcifications, or something that may have been suspicious but had been biopsy proven to be benign. We have a BIRADS 3 designation, which is probably benign. So you find a lesion on screening, you work it up with additional imaging of some sort, and then you think it's probably benign, but you're not sure. So you bring that patient back in 6 months, 12 months, and at 1 year. And at 2 years, if nothing changes, you can convert it to benign. A BIRADS 4 is a suspicious lesion, and suspicious lesions need to be biopsied. BIRADS 5 designates a lesion as highly suspicious. Also needs to be biopsied, but if for some reason you do a needle biopsy and it does not show cancer, that patient needs to go to surgery because the lesion is that suspicious. And BIRADS 6 is a known malignancy. And that's when you already know the patient has cancer and you're looking to see if there is cancer elsewhere in the breast as well. There is also a BIRADS 0, which is an incomplete imaging study. If it's on a mammogram, you need to bring the patient back for additional images. So as you can see here, we go through a process that characterizes the breast, characterizes blood flow to the breast, whether that's through BPE or finding and enhancing mass. And once you've characterized the findings, you can designate a BIRADS. Now, if it's a negative or benign BIRADS, those women are recommended to have yearly mammography, probably benign, as I've mentioned, every 6 months, but you can skip the 18-month. And for probably benign lesions, only about 2% of those should ever end up being malignant. So it's very safe to wait 6 months if you really follow the guidelines for what is probably benign. And then there are the suspicious lesions and the known carcinomas, and the suspicious lesions get biopsied. Thank you.